Dear students, in the previous lectures you had heard a general introduction to the regional anatomy. You heard about the fascias, the muscles, and a couple of general ideas how to dissect a cadaver. In this lecture I continue this talk with detailed information on the so-called structures, the arteries, veins, lymphatic vessels, and the nerves. The structures, as I mentioned, are the arteries, veins, lymph nodes, and the nerves. Let's start with the blood vessels. You probably know this picture from your kindergarten, how the blood circulates. The central component is the heart, from which the pump is blood to two circles, the general circulation and the pulmonary circulation. Now let's describe the general circulation. The principle of the pulmonary circulation is similar. From the heart, the blood goes to the high pressure structures. It's very well known things. This is what we name the arteries. The capillaries are tiny microscopic vessels through which the material exchange, oxygen, nutrition, gases, waste material, and something happens. Then the used blood goes back to the veins and then back to the heart. Whatever I describe, how can we identify the arteries and the veins? The capillaries are the topic of histology. Let's talk about the arteries. So the arteries are the vessels which has high blood pressure and taking the blood out of the heart. Then can be divided to three groups. The large arteries are those one usually bigger than 5 millimeters, which can be really easily dissected, and they have a different function from the rest of them. The most important feature of the large vessels is they have very elastic, rubber-like wall, and this has a very important role in the circulation. During the heart rate, in half of the area, the heart pumps out half of the phases, pumps out the blood, the valves open, and the blood, if we had just solid arteries, has a very high pressure going out, something like this. Whenever the valve is closed and the heart is filled, then practically no blood flow, no zero pressure. The reality is different because we have rubber-like structure in the wall. Whenever the blood is pumped out of the heart, it will not get all of them at the same time out, but fills up the large arteries and the energy is accumulated here. This is why the pressure is lower than in the case of the solid walls. Consequently, it will not damage the tissues. However, moreover, whenever in diastole, whenever the valves are closed, the excess blood accumulated in the vessels will flow out. So we always have even a little bit lower but outflow. So this is the real pressure differences, whatever you know in physiology. So the main function of the large arteries, which has elastic fibers primarily in the wall, is a pressure buffer. The middle-sized arteries we have not a clear-cut definition. It's about thinner than 5 millimeters. These have a different wall structure, not only smaller. And the typical component in the wall is smooth muscle. They are innervated and they can actively change their diameter. And this is their function. Let's imagine we just see this segment. Whenever this segment of the artery contracts, it's difficult to pass the blood through it, so it requires a higher pressure. Whenever during contraction, the blood flow will be smaller. Whenever it's relaxed, it's easier to pass through and more blood flows then. So the smooth muscles in the middle-sized vessels make two functions. It actually controls the blood supply of the organs. It's the distribution is about done by some organ gets blood, some organ less blood, and also the blood pressure. If all of the arteries slightly contract, the central blood pressure increases. It's important to know that most of the organ is not innervated. There is no nerve which controls the cells of the kidney, the liver, the lungs, and whatever. These organs controlled by the central nervous system through blood supply. The central nervous system will innervate the middle-sized arteries, and whenever organ is necessary to work hard, gets more blood and works harder. Whenever it's not necessary to work, because at this particular moment we do not need the function of this organ that much, it will contract and it gets less blood. This is how the organ is functioning. You have to become familiar with a couple of terms. Anastomosis means that connections between parallel running arteries, for instance, between this artery and this artery, there is a cross connection, also here and here. This is what we name anastomosis. This makes more reliable the circulation, because, for instance, if this piece of the artery damage, this artery still gets the blood in this round way, and there will be no problem with the blood supply of the organ. The other term is the end arteries. After a certain point, for instance, this arteries has no partner anymore, no help. So whenever anything happens in these arteries, which is a solely supplier of this piece of the organ, then the organ will die. So those arteries which has no help in the circulation, no side connection, just solely responsible supplying an organ named end arteries. Also another thing is the arteritic arches. It's a specific thing for the anastomosis, which is big, and it has anatomical name because of importance. Especially on the hand and the foot, we have arteritic arches because we have mechanical pressure and sometimes compress the arteries. This is named arcus or arch in English. Also another feature of the arteries which makes the circulation more reliable are the collaterals. On the two sides of the arteries, or one side of the arteries, we have arteries that are coming out of the arteries and later going back. This is what we name the collaterals. This also makes the circulation more reliable. If something happens with the main arteries, especially if it happens slow, these collateral arteries can dilatate and can easily replace it, so we do not waste, do not lose the rest of the limb. Just the collaterals help us circulating. This is why it's important, especially for the surgeons, to know where we have collaterals in the arteries. Another term is pulse arteries. In certain area, we have arteries between the skin and the bone. So if you make a little pressure, slight pressure on the skin on this area, this is the most obvious, best known is the radial artery on the wrist. This is between the skin and the bone. We can feel the pulse, which means how the heart pumps. This is, we can not only measure the heart rate, how many times the heart is pumping, but if somebody has a little experience, it very well can determine the blood pressure. Plus minus 10, an experienced doctor with just feeling the pulse knows what the blood pressure is. There are several areas on the body beside the generally used wrist arteries, the radial arteries. Here we have on the back of the foot, this dorsal pedal artery, which is the end branch of the anterior tibial or the posterior tibial artery. These arteries especially not used for making the pulse, because it's not really easy or obvious, but you can feel the blood supply of the limb. So if somebody has problem in walking, it's painful, it's possible that you have circulatory problem, and you feel the pulse here, it means the pain comes from somewhere else. If you can't feel the pulse, either you don't know where to feel the pulse, or it does have a circulatory problem, and you can send it to an expensive diagnostic value. This is also for the posterior tibial artery just behind the lateral angle. A special thing is the carotid artery with the bifurcation. Here is also between the skin and the vertebrae. And this has a special role in the medical diagnosis. In this artery, the pulse wave is the strongest because it directly comes up from the heart. Consequently, if you cannot feel the pulse here, the heart doesn't function. This is why in forensic medicine, when the people is in shock, he has a very low blood pressure, it is possible that you cannot feel the pulse here because of the very low blood pressure, but the patient is still alive. If you cannot feel the pulse here, where either you are very unskillful or the patient is dead, and this is why this is the point where the best way to check whether the heart of the patient is working or not. Capillaries. The capillaries are tiny vessels of microscopic age. Whatever anatomy is concerned, you have to know what they are doing. And the number one is an obvious thing is feeding, so it's carrying oxygen and nutrition and supply the particular tissue or organ. There is another less known thing is that this works like a central heating. You know, our body works in a standard temperature, 37 centigrade, and every body part. Inside the trunk, it's very crowded, it's very easy to maintain this temperature. However, some areas like the fingers or the ear or the scalp or the face, which is pretty much cools down, there is no, and additionally, these tissues here has a very low energy requirement. They do not produce excess heat. The capillaries work like a central heating. Whatever blood goes in this area, about 1% is utilized for oxygen or nutrition. The rest of them is just passing through and carrying the heat from the body to that to warm up this area. And that's a very important piece of knowledge for the medical doctors. There is a very big difference if you take blood from the vein, which carries used blood, or from the fingers, or also from the earlobe, which has similar very high circulation. This is practically arterial blood. So whenever you get a blood sample from the finger, you get arterial blood. Whenever you get the vein, use venous blood. And this is why, if you want to measure oxygen, glucose, or whatever from the blood, which is used other ways by the tissues, if you use blood from this exposed area, you can very practically arterial blood. The hand, face, ear, nose, these are the most obvious areas. Veins. Veins are vessels which carrying the blood back to the heart. These also have different things. The larger veins are very nicely dissectable, and these are usually alone. The middle-sized veins located in two areas. One is superficial veins, which are running between the skin and the fascia. These form a kind of network, but we have some standard pieces of it. This is very important in the medical practice because from this vein we take samples and also give intravenous injections. They sometimes form the networks. It is what we named rete venosum or venous network, like in the back of the hand and on the back of the foot. The deep middle-sized veins are running along the arteries, and interestingly enough, we also have a pair of veins, so two veins running along the arteries, and sometimes, very frequently, we have cross connections between them. Okay, beside the blood circulation, we have another circulation, a lymphatic circulation, which is open circulation. So blood is completely closed circulation, but the lymphatic circulation is open. How it happens? First of all, you have to be familiar with the lymph. The lymph is a fluid, actually it's an ultrafiltrate. You studied biophysics, so probably very well know what's ultrafiltrate, but let me a little bit explain again. The capillaries are between the arteries and the veins. The wall of the capillaries is very thin, and small molecules, anything below 20 kilodalton, like water, ions, glucose, and whatever, can pass out, and waste material, flow molecular weight can go in, so there is a material exchange. However, in the capillaries, there is a physical pressure. This pressure is needed to push the blood back to the heart. So in the vein, we still have a little pressure, and this pressure is higher than the pressure in the tissues in general. Consequently, for the water molecule, it's much easier to get out, to get in, and certain quantity, large quantity of the water molecules and ions and whatever for low molecular weight, just getting out of the capillary and cannot go back. And this fluid, which gets out of the blood, and it will not join, will not go back to the general circulation, is named the lymph. The lymph is part of the blood, so must go back to the circulation somehow, and this is what we name the lymphatic circulation. So what is the role of the lymphatic circulation? Number one, it takes the lymph back to the general circulation. It's about 3 liters a day, so if the lymphatic circulation would stop for a couple of hours, we would lose so much volume of the blood that we would die. So it's absolutely necessary for us to survive, to carry back this lymph to the general circulation. There is another very useful function, this is the cleaning woman in our body. Whenever the lymph goes out from the vessels and finds the way back to the lymphatic capillaries, it washes the intercellular space. And whatever garbage is then, just general dead cells, broken pieces of fibers, bacterium, tumor cells, and whatever, will get carried into the circulation, and the extracellular space will be cleaned. The first part of the lymphatic circulation is the lymphatic capillaries, as this kind of animation shows. It's made of very loosely related endothelial cells, and the fluid goes there, facilitated by valves and external pressure from the muscles, and the lymph starts circulating. The circulation is ensured by valves in the lymphatic vessels, so whenever the muscle moves, it compresses, it cannot go back just in one direction, which allowed by the valves. Whenever it releases, it also cannot flow it back, but comes the next one. So for the healthy lymphatic circulation, you need movement of the muscle. This is why more or less continuous movement, frequent movement is good or necessary for the normal lymphatic circulation. Because the lymphatic circulation, as I mentioned, carries a lot of garbage, it's best not to get back to the general circulation, but filtered out. And these filters are the lymph nodes. So the lymph nodes, the function of the lymph nodes, it filters out everything which is not wanted, particles, and also poisonous liquids or poisonous dissolved materials there. Usually we have not just one lymph node, but a series of lymph nodes after each other until the end of the lymphatic circulation. The lymph nodes we have named the primary lymph node, those lymph nodes which directly gets the lymph from the tissue, and secondary lymph nodes which gets the lymph from the other lymph node. Consequently, once again, I have a cascade of lymph nodes and many. All the lymph nodes which are not primary, we usually name just secondary. If the lymphatic circulation is blocked, the water is accumulated and other low molecular weight component in the skin, and this is what we named edema. We have a large lymphatic vessel. The small lymphatic vessels are not dissectable. Maybe the largest can be. The general principle is that we have 2 lumbar trunks, which drains the lower limb and most of the abdomen. The intestinal trunk, which gets the lymph from the small intestine. This is a common reservoir, the cisterna chyli, which is the level of the diaphragm, and this carries the thoracic duct to the venous angle. Meanwhile, it gets 3 groups of lymphatic vessels: the bronchomediastinal trunk, which is from the chest, and the subclavian trunk for the upper limb, and the jugular trunk from the head and the neck. We have 2 lymphatic systems. The big one is the ductus thoracicus, which collects the blood everywhere from below the diaphragm and the right upper corner of the body. In the the right one is collected by the truncus lymphaticus dexter, which has just 3 branches: the bronchomediastinal, the subclavian, and the jugular. Finally, the lymphatic vessel goes to the angulus venosus. Maybe you can see this little line. This is the ductus thoracicus and the similar structures in the left one. Angulus venosus is the meeting of the main vein of the upper limb, the subclavian vein, and the main vein of the head and the neck, the internal jugular vein. Nervous system. As you know from the kindergarten, we have a central and peripheral nervous system. The central nervous system contains the brain and the spinal cord, and the peripheral nervous system has the nerves, these are practically nerve fibers, and some ganglion where we have nerve cell bodies. What they are, you just want to call your knowledge on the histological structure of the nervous tissue. The body of the nerve cell, the neuron, this is what we name the perikaryon, has many processes, usually some short processes, these are picking up the signals, these are the dendrite, and one long process is carrying away the already processed answer of the nerve cells and give over to the other nerve cells or other tissues like muscles. The cell bodies located in the central nervous system, either on the surface, that we name cortex, or embedded in the gray matter, this is what we name nuclei. You can identify them because of the grayish, brownish gray area. The fibers are in a white matter, white area. In the peripheral nervous system, we have a ganglia in certain location, which also has perikaryon cell bodies. The axons is the structure which giving over to the information, and you have to know these three terms and clearly separate from each other. Axon, this yellow line represents that. This is the part of the neuron which carrying the signal to the partner. Around the axon we have axon sheaths. These are protecting, electrically isolating, and also allows a faster conduction on them. You will study in biophysics and also physiology how it's done. The axon and its sheaths together name the nerve fiber. The third named nerve is a bundle of nerve fibers. You can see many nerve fibers has a wrapping. This has a bigger and even bigger wrapping. This is what you study in details in histology. So the nerve cells is large quantities of axons and its sheaths packed together in a certain way. So once again, axon, part of the nerve cell, nerve fibers. The axon and the axon sheaths and the nerve is a big structure. The axon can be in the central nervous system and in the periphery. In the central nervous system, parallel running axons, practically nerve fibers, named pathways. This makes the white matter of the central nervous system, both the spinal cord and the brain. In the peripheral nervous system, these are the nerves. These are the elongated, relatively hard, yellowish structures, what you dissect as nerve. Nerve, we have two sets of nerve based on the origin, some of them coming off the brain. We have 12 pairs of so-called cranial nerves, this directly coming out of the brain. And we have spinal nerves, which coming off the spinal cord. We have several of them. Let's talk about a little bit later on that. One more piece of information before starting that. We have functionally three types of nerves. Sensory, which only carries incoming signals from the receptors to the central nervous system. Motoric, which carries outgoing signals to move muscles, glands, and whatever. And a mixed, which has both sensory and motoric. Most of the nerves are mixed nerves. For understanding some of the peripheral nerves, let me give a kind of short introduction to the spinal nerves. The spinal nerves coming out of the spinal cord, and there are four areas where the nerves coming out of the spinal cord. These spinal cord, from many files, radicular files, they will join to a certain group, and this is what we named rootlets. We have a dorsal rootlets, which is on the back, and this is sensory. You can see this bump. This is a ganglion with sensory nerve cells. And we have a ventral rootlets in which the radicular files collect there. And this is outgoing fibers, motoric fibers. So the dorsal, the information goes in the ventral, information goes out. This green circle want to represent the area where the spinal nerve can get out of the vertebral canal. And this little segment of the fibers, the united dorsal and the ventral rootlets, is the spinal nerve. Very soon it divides to a usually thinner dorsal and a usually thicker ventral ramus. The dorsal branch or dorsal ramus always remain segmental, and this supplies a certain segment of the back, actually the area between the scapulas, so this is the area where this supplies, and motorically and sensorily. The ventral branch very frequently, normally, forms networks, plexuses, and this is what I spend a few words on that. One more term you have to understand, the segments. If you see that the spinal cord, let's imagine these outgoing fibers are cut short, we have continuously outgoing fibers from the spinal cord, these are radicular files. However, because these nerves can go out just in a certain area from the vertebral canal, the intervertebral foramen, they must gang to a spinal nerve. That piece of the spinal cord, from which the fibers will join to a single pair of spinal nerves, this is what we name a spinal cord segment. So this is one piece of the spinal cord which goes into the spinal nerve. In the body surface we can make a very nice map that every single line represented by different color is innervated from a spinal nerve coming from a certain segment. These stripes on the skin which is innervated by a certain segment we named dermatomes. Okay, finally the plexuses. The plexuses are networks, once again, of the ventri rami of the spinal nerve. Most of them, but not all of them, form plexuses. In the cervical plexus, in the cervical area, the first four cervical spinal nerve making that, and this will innervate the neck, partially ahead, and the diaphragm. This is for embryological reason. You will next semester understand why. The brachial plexus is the lower cervical part, including the first thoracic. This is the nerves which innervates the upper limb. It has two sets of branches. One, the short branches or girdle branches, which remain on the area where the upper limb takes its origin and moves the originating muscles, and long branches which goes down to the upper limb. The fibers join and reorganize twice. First, the ventral rami gang up to three groups. These are named trunks. We have a superior, a middle, and the inferior one. And below the clavicule, they also reorganize, exchange their position, and relative to the axillary artery, they have also three groups. This is what we named cords. We have a medial, a lateral, and a posterior cord. The branches of them you will study in details in the dissecting room. The intercostal nerves, which are separated by the ribs, will not join. There is no plexus at the level of the thoracic region. The ventral rami of the spinal cord of the thoracic region named intercostal nerves, so these two things are identical. Below that, beginning the lower thoracic till the fourth lumbar, also the ventral rami joining to a network, and this network has various branches. This is what we named the lumbar plexus. Lumbar plexus especially innervates the abdominal wall, part of the pelvis, and a little of the lower limb, especially the anterior aspect of the thigh. The sacral plexus is below that, from the fourth lumbar all the way down, and this divided into two subparts. This is the upper part, is the sciatic plexus, plexus sciaticus, from the fourth lumbar till the third sacral, and this supplies primarily the lower limb and the perineal region. And we have the pudendlohemorrhoidal plexus, the lower part below the third sacral, and till all the way to the second coccygeal, and this is the last plexus. And finally, I want to show you again at least a segment of this film, whatever I showed you for dissection. Very important how to assemble the blade on the scalpel. So once again, parallel this oblique structure, taking on the hand, the back of the thing is putting that. Removal, not breaking it, that, gently pushing up with other nail push down. When it's liberated, you can easily pull down. Once again, after you remove the blade, do not forget to dispose of properly to a very special garbage container. Whenever you make the first cut, you have to get a given depth. In this case, you have to, especially when you expect superficial structure, you have to be very careful. The first step is to remove all the skin. Whenever you remove the skin, you have to leave down everything, fat, fascia, whatever. This makes you a very nice dissection. Whenever you, the dissection is that very forceful way. You pull with the forceps, and it will build a kind of spider web-like structure group, which a very easy hand you can cut with a sharp blade. And this way you can see a very nice clear picture. If you do it properly, no fat remains on the skin, and all the fat will remain down, and this will be removed in the next step as a next layer. Practically, the rest of them was seen on the previous lecture. Once again, this film you can find in the handouts chapter of our internet site of the anatomy department. I suggest to study it. This is what I wanted to talk about today. Thank you very much for your attention.